Hello everyone and welcome to our video on osteoporosis drugs. In this video I'll focus on drugs used to treat osteoporosis, but let me start with a general point of therapy for patients with osteoporosis. All patients who have osteoporosis need lifestyle modification. This means a recommendation to do weight-bearing exercise, which can increase bone density, to avoid heavy alcohol use, which is associated with osteoporosis, and also to quit smoking, which is also associated with osteoporosis. In addition to these lifestyle factors, all patients with osteoporosis should take calcium and vitamin D supplementation to make sure they get sufficient levels of these nutrients. Beyond those items on the last slide, the first-line therapy in treating osteoporosis is a class of drugs called the bisphosphonates. All of these drugs end in dronate, like alendronate, pamidronate, ibandronate, zolendronate, and these drugs all work because they are analogs of pyrophosphate. So in the biochemistry section, I have two videos on synthesis of pyrimidines and purines, and in those videos I talk about how pyrophosphate is important for the synthesis of nucleotides. For example, if you look at the bottom of the screen, this is one of the reactions of purine synthesis by cells in our body. Ribose 5-phosphate is converted to a molecule called PRPP, which contains pyrophosphate. Pyrophosphate is two phosphate groups linked to an oxygen. So this reaction requires pyrophosphate, as do many other reactions for making nucleotides. You need pyrophosphate to make pyrimidines and purines, to make purines like ATP and GTP, and pyrimidines like uridine, cytidine, and thymidine. So pyrophosphate is two phosphates connected by an oxygen molecule. A bisphosphonate is two phosphate groups connected by a carbon molecule, and also attached to that carbon molecule are two side chains called R1 and R2. And the two side chains R1 and R2 vary among the different bisphosphonate drugs, and this is what's responsible for their different properties. Some of them are oral and some of them are IV drugs. The reason these drugs are effective in osteoporosis is because the phosphonate groups bind to calcium, and therefore these drugs accumulate in bone. They are then taken up by osteoclasts, which are trying to break down bone, and when the bisphosphonate drug gets inside the osteoclast, it inhibits the osteoclast's activity. There are a number of mechanisms by which the bisphosphonate can do this. Some of them have to do with inhibiting nucleotide synthesis in the osteoclast, but there are other mechanisms as well. But the key point is that the phosphonate group binds to calcium, and that makes these drugs readily taken up by osteoclasts. Some of these are oral drugs. In particular, alendronate and risendronate are oral bisphosphonate drugs, and the main side effect of the oral drugs is upper GI upset. Patients who take these drugs often develop reflux, so they complain of heartburn. They can develop esophagitis and even sometimes esophageal ulcers. And this is all due to a local effect of the bisphosphonate molecule on the GI mucosa. The good news is these drugs usually only have to be taken once a week, and when the patient does take them, if they follow certain steps, they're less likely to have GI upset. So they're advised to take them with a big glass of water on an empty stomach first thing in the morning, and then remain upright for 30 minutes and don't lie down in bed. If patients follow these guidelines here, when they take them every week, they're less likely to develop GI upset. Some of the other bisphosphonates are IV drugs. For example, pamidronate, ibandronate, and zolendronate are all IV drugs. These are administered to patients in an infusion center, and the main side effect of the IV drugs is flu-like symptoms. These often occur a day or two after infusion. Patients can develop low-grade fevers and myalgias. These can be treated with ibuprofen and acetaminophen. The nice thing about the IV drugs in terms of bisphosphonates is that many of them are dosed every 3 months. Some are even dosed annually, meaning the patient just has to come into the infusion center once per year and get an infusion of the drug, and then they are set for another year. Two other potential complications of bisphosphonate drugs are atypical femur fractures and osteonecrosis of the jaw. These are both rare, serious complications that have been associated with both the IV and oral drugs. Luckily, they're very rare, but when they do occur, they're very serious. So let's talk about the atypical femur fractures first. Most hip fractures are intracapsular, meaning they occur in the femoral neck or head. So right here on this drawing, either at the neck of the femur or at the head. Some are also intratrochanteric, which means they occur right above the trochanters here, the greater and lesser trochanter. And these are the type of hip fractures that are associated with trauma that you commonly see among elderly patients. Atypical femur fractures are femur fractures that occur below the lesser trochanter or in the diaphysis of the femoral bone, so-called diaphyseal fractures. So these occur below the trochanter here or down in the diaphysis. These often happen with no or minimal trauma, and they've been reported among patients taking the bisphosphonates, and they are a rare but serious complication of these drugs. The other rare but serious complication of bisphosphonate drugs is jaw osteonecrosis, which is avascular necrosis of the jaw caused by a bisphosphonate drug. This presents as pain and swelling usually in the mandible, as shown in this picture on the screen here. It may lead to exposed bone and local infection. It can lead to a pathologic fracture of the jaw, which is a fracture of the jaw that occurs with no or minimal trauma related to underlying osteonecrosis. Most of the case reports of this have occurred in the setting of patients with significant dental disease, and for this reason, some doctors don't give bisphosphonates to patients who have a lot of dental problems. Our next drug used to treat osteoporosis is teriparatide. This is a recombinant version of human parathyroid hormone. Now you might think that giving parathyroid hormone, which causes bone resorption, is a bad idea among patients with osteoporosis, but it turns out the drug works, and this is the reason why. Continuous administration of parathyroid hormone, like the way your parathyroid gland delivers the hormone to bones, leads to bone resorption and raises the serum calcium. This is important physiologically. This is the way your parathyroid gland works. However, if you artificially administer a low-dose, once-daily bolus of parathyroid hormone, you get a different effect. In this case, you get increased bone mass. The reason for this different effect is not known, but you will see if you give a once-daily bolus of parathyroid hormone to a patient, increased osteoblast bone formation. And this is in contrast with many therapies for osteoporosis which inhibit osteoclast. Teriparatide, which is synthetic PTH, increases the bone formation by osteoblasts. And so for this reason, recombinant PTH, which is teriparatide, can be given as a subcutaneous daily injection, and it will lead to more bone formation. Potential adverse effects of teriparatide are shown on this slide. First of all, the drug can cause a brief rise in serum calcium. This should make sense to you. It's a synthetic version of parathyroid hormone, so naturally it can raise the serum calcium. Now the drug has a quick on and off effect over hours, and it rarely leads to very high calcium levels or symptomatic hypercalcemia, but you can see a brief rise in the serum calcium level. In addition, this drug has always had a theoretical risk of causing bone tumors like osteosarcoma. Now, very few cases of bone tumors among patients taking this drug have been reported, but high dosages used for a long duration in rats have been shown to cause cancer, so this is always a theoretical risk of administering this drug for a long period of time. Our next osteoporosis drug is raloxifene, which is a SERM. A SERM is a selective estrogen receptor modulator. It gets its name because it has estrogen actions on bone, but anti-estrogen effects in breast tissue and in the uterus, hence the term selective estrogen receptor modulator. This drug can also be used for the prevention of breast cancer. That's because it blocks estrogen effects in breast tissue. And many of its side effects are related to estrogen. It can cause hot flashes by blocking estrogen effects, and it's associated with thromboembolic disease like deep vein thrombosis and pulmonary embolism, just like many other estrogen drugs. The good news about this drug, and the reason it's often favored in women with osteoporosis, is because it has minimal effects on the uterus. Some drugs that activate estrogen receptors can cause bleeding or endometrial hyperplasia or endometrial cancer, but that is not seen with this drug because it has very few effects on the uterus. Calcitonin is a hormone normally produced by the thyroid gland. It's synthesized by the parafollicular cells of the thyroid gland, which are also called C cells. This hormone binds to osteoclasts and inhibits bone resorption, and there is a commercially available form of calcitonin that is derived from salmon, so it's actually derived from fish. The calcitonin from fish is collected and it's marketed as a drug, and this is one potential therapy to treat osteoporosis. Our last osteoporosis drug is denosumab. Denosumab is a monoclonal antibody to the rank ligand. All drugs that end in AB are usually antibodies, and in this case, it's an antibody to the rank ligand. The rank ligand is expressed by osteoblasts, as shown in this picture. It binds to the rank receptor on osteoclasts and leads to the activation of osteoclasts and therefore bone breakdown. So this antibody binds and blocks the rank ligand so that it cannot bind to rank. This leads to a blocking of osteoblast activation of osteoclasts. And that concludes our video on osteoporosis drugs.